Finally, we talk about posterior ankle pain differential diagnoses. Achilles tendinopathy should be distinguished between the mid portion and the insertional types. Management changes slightly, but importantly, especially in terms of outcomes. Also important is to rule out the Achilles tendon rupture, which is a clinical diagnosis, and to consider the differential diagnoses. For the Achilles tendon partial tear or rupture, it's typically a result of a sudden ballistic movement resulting in pain, a pop feeling or sound, and the sensation of being kicked in the tendon. Overuse tendinopathies are more typical, and sometimes it's difficult for the patient or athlete to identify the time of onset, but typically a relatively excessive overload can be identified in terms of things like changing training technique, surface, or volume. Differential diagnoses that are common, especially in adolescents, would be Sever's disease or calcaneal epiphysitis. Other differential diagnoses include the retrocalcaneal bursitis or posterior ankle impingement syndrome. Less common differential diagnoses would be an accessory soleus muscle, sural neuroma or neuropathy, an inflammatory cause of the insertional Achilles tendinopathy, also called enthesitis, and referred pain. Investigations. For the Achilles tendon rupture, this is a clinical diagnosis, and the ultrasound, diagnostic ultrasound, particularly in plantar flexion, may be useful to clarify if the torn ends are so retracted that it doesn't allow for a conservative management option. Treatment, so distinguishing between mid-portion and insertional tendinopathy. So mid-portion has been well studied with level 1 evidence showing that Hogan-Alfredson's painful heel drops protocol for 6 to 12 weeks is very effective. There's been more recent evidence looking at the cadence of the heel drop, taking about 4 seconds in the descent from the top of the heel drop down to below as far as possible the step seems to improve outcomes. This contrasts with insertional tendinopathy, where the heel drops over the edge of the step only resulted in at most 1 in 3 successes. 2 and 3 would seem not to improve over that same time frame. And it seems that's a result of the compressive load of the calcaneal prominence on the complex of the Achilles insertion and the retrocalcaneal bursa, which is closely, intimately placed in that region. One modification, where the heel drop ended at the floor as opposed to over the step, resulted in at least a doubling in terms of positive outcomes. Adding a heel raise and avoiding stretching this area, all again to reduce the compressive load onto the calcaneal prominence, seem to improve outcomes for insertional Achilles tendinopathy. So if there's a positive response with this exercise regimen, then maintenance for 6 to 12 months is warranted. However, if there's no response, it's still useful to continue exercise, but to add some further management suggestions, such as evaluating the posterior chain to look for dysfunctions that can be treated, as well as adding methods to try and improve vascular flow to these areas that are poorly vascularized, such as adding a nitric oxide donor patch or extracorporeal shockwave therapy for a few months. Should these further fail, then further intervention may be necessary, such as sclerosing treatment, needle fenestration, and platelet-rich plasma injections in the context particularly of a partial tear. Failing all these, surgical management would be warranted. Now, looking at retrocalcaneal bursitis, it may be important to look at what is called the enthesis organ, which is the complex of the retrocalcaneal bursa, the insertion of the Achilles tendon, and the adjacent cartilage-covered calcaneus. Because these structures are so intimately related at the posterior calcaneal, to the posterior calcaneal prominence, it predisposes to mechanical irritation of both bursa and tendon, especially with forced dorsiflexion when the calcaneus impinges on these both. So on exam, the tendon inserts onto the lower aspect of the calcaneus, and that's where true enthesopathy would be. However, much of the pathology is more proximal to that, where the bursa, upper calcaneus, and tendon interface. In an attempt to distinguish between these two, a tensile load with just straight up hopping would provoke isolated enthesopathy, whereas if one added a hop and a lunge into dorsiflexion combined, this would provide both a compressive and a tensile load, so affecting the whole enthesis organ. Investigations, such as an ultrasound or cross-sectional imaging like an MRI, would distinguish tendinopathy and bursitis, even though both may occur simultaneously. In the context of enthesopathy, this may raise suspicion for inflammatory arthropathy and prompt inflammatory serology. Similar differential diagnosis to consider with Achilles tendinopathy. And for treatment, in the acute phase, treatment of inflammation with topical or oral NSAIDs and reducing the compressive loads such as with heel lifts would be useful. Modified Alfredson heel drops protocol to the ground rather than over the edge reduces the repeat compressive loads onto the enthesis organ. Failing that, troweling extracorporeal shockwave therapy, nitroglycerin patches, and sclerosing agents may still be useful. Failing that, particularly if there's an excessive calcaneal prominence called a Haglund's deformity, surgery would be warranted. Finally, we'll review calcaneal fracture. These can be divided into those that are extra-articular versus those that are intra-articular in terms of management. The extra-articular fracture is less common. Its acute treatment involves non-weight-bearing compression, splinting for 48 to 72 hours with active range of motion as pain allows. Definitive treatment would involve immobilization depending on where the fracture is. In terms of an anterior process fracture, a medial process fracture or a lateral process fracture, which is a result of forced plantar flexion, eversion, or inversion, respectively. Short leg walking cast for 4 weeks is often sufficient. For a calcaneal tuberosity fracture, as you can see in image E, this is typically a dorsiflexion injury involving Achilles stress, and a short leg non-weight-bearing cast at 5 to 10 degrees Aquinas for 6 weeks is usually sufficient immobilization. Sustentaculum tali fracture is typically combined with other fractures and involves significant inversion, as you can see it in image B on the right. And this immobilization would involve short leg non-weight-bearing cast for 6 to 8 weeks. And finally, a body fracture of the calcaneus does not require immobilization, and active functional progression is sufficient. And this is image F. Healing time is typically 6 to 12 weeks for complete return to function, but it's possible that pain and stiffness continue for months. In terms of repeating the X-ray following the initial diagnosis, calcaneal tuberosity fracture, 1 week after casting is necessary to check alignment, and for all immobilized fractures after immobilization is discontinued, as well as for delayed clinical healing. That would be another indication for a repeat X-ray. Orthopedic consultation is necessary in extra-articular calcaneal fractures for displaced fractures, persistent pain, and non-union. More commonly, calcaneal fractures are intra-articular, involving the subtalar joint. It's the most common calcaneus fracture encountered in primary care, and the mechanism of injury is a fall from height landing on heels, absorbing the full body weight. The force vector is more critical than the height of the fall, and calcaneus compressive force into the lateral talar process. Investigations, such as an X-ray looking at Bowler's angle, can help make the diagnosis. As you can see, what would be a normal and an abnormal Bowler's angle in the images on the top on the right. CT is often necessary to determine the severity of the subtalar joint involvement for preoperative planning. Calcaneal fractures are bilateral in 10% of cases, and up to 10% of cases are associated with a thoracolumbar compression or burst fracture, commonly between levels T11 to L2. So it's important to clinically consider those in particularly the bilateral calcaneal fractures. Treatment, there's many treatment methods, such as no reduction and early immobilization, cast immobilization, and open reduction internal fixation. Thus far, it's unclear the benefit of operative versus non-operative management of these fractures, and there's more emphasis recently on early ORIF of displaced fragments to restore subtalar joint integrity and try to prevent post-traumatic arthritis. And yet, poor clinical results regardless of treatment, as it's difficult really to refashion the smooth subtalar joint surface. So thanks for listening to this. In summary, the ankle is the most commonly injured joint seen in the sport and exercise medicine clinic. I hope you become aware of a broader array of possible differential diagnoses as you approach your next ankle injury, and organizing your differential diagnosis anatomically in this way may help you to become more comprehensive, accurate, and efficient in approaching the next ankle injury that comes into your practice. Thanks for your attention.